go.
Then Aaron, will you send the recording to us in an email?
Yes, I can send the recording in an email. That it'll include the Zoom link, and it's recorded via Zoom, and I can send that out to everybody, and we'll have it also recorded in our video index that Katie Reitmeyer had started. So this will be a question and answer with Dr. Casey.
Thank you.
And we get the link from Regina Gore after the meeting, so sometimes it can take 1 or 2 days before we send it out.
Oh, that's no rush. I just wondered. Thank you.
Mm-hmm.
And I'll have David Muir fact check us as we go along. He got a lot of practice last night fact checking, so he said he'd double in, and if I give any bad information, you'll hear from him.
He might have some pre-fact checks
Oh.
too. I don't know.
So do we have any questions? Sure, somebody does.
I have type 2 trigeminal neuralgia, and I'm having some problems in my legs, and there's a possibility I have peripheral neuropathy in my legs. And I have 2 questions. Number one, is there any possible link between my trigeminal neuralgia and peripheral neuropathy? And number 2, the doctor had said something about the possibility of radio frequency ablation for my lower back. And my understanding of type 2 trigeminal neuralgia is that surgical procedures are generally not recommended, and that you could potentially be worse afterwards. And if I were to get radio frequency ablation on my lower back, would that be the same situation as it would be for my trigeminal neuralgia?
That has about 5 parts, so I'll try to go back one by one. And if I miss one, call me on it. But one thing that's important actually for the whole group, we used to say type 1 and type 2. The term atypical is being phased out completely, but actually both atypical and type 2 are being replaced in the literature by persistent idiopathic face pain. And the reason for that is that a significant number, not everybody, but a significant number of the previously called type 2 PIFP patients have other pathologies than cross compression. They have other sources for their face pain, quite an interesting differential. And some of you are obviously familiar with them. There's dental and there's sinus and so on. But the point was that there is a subgroup of people that aren't classic that will respond, by the way, to surgery. Patients who have what we previously called type 2, now PIFP, who have attacks of any type, whether it's an attack of numbness or an attack of tingling in the face or even a sharp attack pain, even if they have just a few of those mixed in with their other symptoms, they've responded surprisingly well to surgery, to standard microvascular decompression, with about a 70-75% success rate. So not the same as a type 1 patient, where it's more like 85 to 88%, at least in our experience. So that's important for the type 2 patients previously to be sort of subgrouped a bit from the PIFP patients. As regards radio frequency, either of the face or the back, do recall that that's trying to damage the nerve with heat. The problem with damaging any nerve, whether it be in the face or in the back, is that if the nerve decides to scar and become more painful, what's called a neuroma, that can actually be a problem that's been created by the lesion. And certainly in this group, there are a number of people who had radio frequency of the face who reported complete numbness afterwards and then subsequently continued to have pain, previously erroneously called anesthesia dolorosa. it is an anesthesia, that's why they still have pain. But in fact, it's de-innervation pain, just the same as if we accidentally cut a nerve root. Back to the lumbar spine, having offered it to patients way back when we first started at Pittsburgh, we did a cross study. Did the patients who got radiofrequency versus those that got a block and went on to a regular surgery, did they do any better or whatever? 88% of the people who got the blocks back then wound up going to some surgical procedure. Not always a fusion, not always a huge thing, but because they had root pain, whether it be thoracic root pain or whatever, and as long as that root pain was structural, meaning related to some changes in the little opening in the spine called the foramen, then the radiofrequency got done. But in retrospect, it didn't help the patient and it didn't help us to stave things off, which is the only reason we tend to do blocks at all. Trigeminal blocks, sphenopalatine blocks up here and then blocks elsewhere are just designed usually to put the nerve to sleep and see what the patient says is better and determine, okay, that is the subject nerve. I just reviewed a paper for a journal and they were trying to use selective nerve root blocks preoperatively to project what the outcomes will be, and there's no correlation at all. So that's in a nutshell. Type 2, with the subgroup of people who have attacks, do okay in surgery. Those that are constantly numb or constantly deep burning tend to do less well. You're correct with microvascular decompression. They don't respond at all to Gamma Knife. They don't respond very well to balloon compression. There is some change with radiofrequency, but it oftentimes comes at a cost of more numbness or more static pain. But sometimes, as I said, you can reduce any sharp components that came. Did I cover most of the points? I don't remember if I skipped over any.
Yeah, I think you did. Is there any relationship between having the trigeminal and
Oh, no, good question. Obviously, the only connection that we've established is people who have MS can have face pain, and people who have face pain can have peripheral symptoms. But if your doctor specifically used the word peripheral neuropathy, meaning they stuck little pins and did the feather and all those tests, not the EMG, but actual testing, then MS would be the only logical thing. And in all deference to your tender age, you would not be somebody that we'd start saying, oh yeah, she's got MS. So other things cause peripheral neuropathy, the most common of which are the B vitamins just not being, the serum levels not being what the patient actually needs. The problem with the serum levels as they exist is they're so wide that some patients need a lot more. And many of the patients in this organization have proven that to docs by saying, I took this much B12 and my face pain got somewhat better. So there was that study in Australia that the group out of Sydney did, which showed that. So that's a more common cause of peripheral neuropathy in folks over the tender age of 40, which I peg you at a little bit more than 40.
Thank you.
Oh, Michael has his hand raised.
Hi, Dr. Casey. December of 2022, I'm fully vaccinated for COVID-19, but I still got infected by the different variant. Or maybe the vaccine itself, maybe 90%, efficacies of that. And it was really horrifying, for a couple of weeks, I was in extremely painful. Now we are about to face another winter here. I will intend to go to and take COVID-19, vaccination. But from your experience, whether COVID-19 and trigeminal neuralgia, do they kind of, how do I say that the COVID will increase the kind of pain experience that trigeminal neuralgia patients, have, And the second part of that is that within, say, 5 days, they recommend to take the Paxlovid. Do you think that if you had infected with COVID and you got trigeminal neuralgia, should you take Paxlovid to kind of reduce the so-called the disease itself?
Okay, two good questions. Around the time of the first, what was truly called the pandemic, with so many people dying and so on, at least those of us, Mark Linsky, myself, I think Jeff thought that, and Zimmerman, and we thought we were hearing from patients more often, patients who previously were okay on medicines or kind of stable, and we thought we heard more. But when we asked the general MAB guys across the board, did you think COVID resulted in more of your TN patients tipping over, meaning they started to call and say, hey, something's happening? And we got a funny group of answers. Some people said, well, I was hearing from people and they were bumping their medicines and this and that. So here's our deduction from all that, because obviously hardly scientific. But COVID does get into the brain. That's why there's long COVID and some of the things that happen. Anything that gets into the brain will cause the proteins in the cerebral spinal fluid. There's a protein, a glucose, and water, and it'll change them. And typically they'll get thicker, meaning the immunoglobulins, the body's defense system, which goes even in viruses such as COVID, will get fired up, which is why headache and malaise and they're just not kind of feeling with the program is so common across all the different variants, even if it doesn't go to pulmonary or cardiac. So that's probably as good an explanation, because we're very aware that people who get flu, kids who get whooping cough and so on, seem to get tipped over with their facial pain. Paxlovid is a very interesting thing. It's with no disrespect to your geriatric doctors, the same as the stuff that's being pushed for Alzheimer's. Nobody has a study that showed that in someone who actually has Alzheimer's, it made them any better. They keep talking about folks that are mildly cognitively impaired, meaning all of us, especially most of the people in the Senate. But on top of it, they never really proved that it fixed Alzheimer's. The same is true with right now with COVID-19 and its multiple variants. There's no clinical evidence that Paxlovid cured you if you already had it. It has appeared in some small groups, not a lot of groups, that maybe the pulmonary event isn't as big, but now with these latest variants, the pulmonary event isn't as big. So no, I wouldn't recommend, because Paxlovid has its drawbacks. It's not a benign medicine. I wouldn't recommend just because you have TN, if you get COVID, to jump on to Paxlovid ahead of time. Obviously, if based on your COVID illness, your physician who's seeing you, who's taking your vital signs and keeping track, if he thinks he sees a pneumonia developing or something, then obviously that would be a different indication. But taking it just to prevent possible exacerbation of the TN won't work. What will probably work better is the fact that because that's inflammatory materials trying to fight the virus, and that's what's inflaming your nerve, taking a non-steroidal, again with your doctor's advice as to how much, taking a non-steroidal as soon as you started any cold symptom, whether it be flu, COVID, RSV, whatever's going to be going around this year, will help with the pain system, because all pain, all neuropathic pain, all regular pain is accompanied by an inflammatory component, because after all, pain is a warning to the body. So of course the body has to respond. Getting it to sort of tone that response down is why we take aspirin for a headache or Motrin for a knee that hurts. Same idea here.
Thanks, Doc.
I have a
Anything
question.
What's that?
I have a question. Dr. Casey, I have PIFP, and when an MRI was done last year, they did it without contrast, and I was wondering, would it have been better to have with and without contrast?
Yes, if the question that the MRI was seeking to answer was, what are the possible differential of face pain? Then
Mhm.
yes, a 3.0 Tesla, not a 1.5, as well as contrast, as well as either a Fiesta or what's called a CIS, CISS sequence. Those three parts, 3.0 Tesla with and without contrast, Fiesta CIS is the new standard worldwide for patients who are presenting with a question of neurovascular conflict, which is what the cranial nerve compression syndromes from certain types of basilar insufficiency and so on, that's what they're lumped under from the radiologist standpoint. So it gives them a starting place to say, okay, patient has neurovascular conflict, bang, 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 here's what we're going to do. So yeah, asking your doctor for a 3.0 Tesla with and without Fiesta or CIS is the way to go. Where do you live?
I live in the Chicago area, a suburb outside of Chicago.
Well, the Advent system there, when I was living out that way, and the folks at Northwestern Memorial, a little further out there, I think out at Arlington Heights or about there, they have these types of machines because I've sent patients with other indications there. But obviously your system or your physician may have the same access.
Yeah, I was gonna ask you about the machines, like the Fiesta, not everybody has that. So yeah, I have access to Northwestern Memorial Health. They've got, yeah, and but I had asked the neurosurgeon, actually the PA, if I could get with and without contrast, and she said, no, we only do the with contrast when we suspect like a blood clot or something. And I'm
Right, she's talking about, well, remember, you're 23 of 100,000 patients in the world. So the PA has never probably seen a PIFP, a true PIFP, and they probably don't hear very much about face pain because most medical students don't either. So yeah, her standard response would be tumor, blood clot, some reason like that. That's okay. You're not the standard, and you don't want to be the standard. So you can just touch base with them and say, hey, I think I need a more detailed study.
okay, thank you.
Sure.
Dr. Casey, I have a question. My name is Roseanne. You spoke with my husband and I about, I would say, less than a year ago, my husband, Joe. And at the time, he was diagnosed in 2016 with TN, and he was diagnosed with classic. He was a patient of Dr. Brown's, and Dr. Brown said he clearly saw another compression under the trigeminal nerve after a failed MVD. And since Dr. Brown retired and we were seeking out other neurosurgeons are now saying that it's definitely not TN1 and it's post-traumatic atypical neuropathic pain. And I've spoken to you about it. We saw two doctors, one in Manhattan, one in New Jersey, and we were going along those lines. But in the interim, we sought out an oral facial pain specialist, and he changed up Joe's medicine. And he was on 1,800 milligrams of carbamazepine, and now he's we lessened the carbamazepine to 800 milligrams, and he is now on Lyrica and Cymbalta, and it seems to have been calming it down. But both neurosurgeons that we're dealing with and the oral facial pain specialist both still is suggesting it was not TN1 and it is now post-traumatic facial pain. But now in the interim of even that, now we just received another MRI just through the neurologist just to do a check-in, and it's strongly indicating a possibility of MS. So I You have two doctors that we're going to see in October. So we haven't gotten to that point yet with seeing the doctors. But do you have any advice for us, being now that we've gone from classic? And I wholeheartedly trusted Dr. Brown, saying that there was another compression underneath. Other surgeons had strongly said there is no compression, so it's not TN1, and now it's possible MS. Do you have any advice for me when I go see the MS specialist here in Manhattan for me? Because now we're kind of just like,
Just so I give you reasonable advice, take me back just before you, Joe, and Dr. Brown were going to do the first operation. What was his pain?
he had just classic shocks, just electric shocks. The
Okay. And
Yeah.
on one side, not both sides, right?
one side.
Okay. When he woke up from surgery on post-op day 3, what did he think about his face?
So the MVD was done, post day 3 was okay. As soon as the steroids were being tapered down, that's when the pain started. And that was at Cornell in Manhattan. And two or 3 months later, we sought out Dr. Brown, and Dr. Brown performed a balloon compression, which gave him,
Let me just back you up. When you said the pain came back after the steroids were tapered, how did it come back? Exactly as before surgery, or now it was different?
it was
Or painful?
worse pain, and it was in different areas of his face. So it went to V1, V2, and V3 after the surgery.
Okay, where it hadn't been before the surgery.
Well, the surgery was just V2.
All right, so there's a couple of possibilities, and they're all possibilities, obviously. I don't have evidence of the records. But first of all, 5% of people with MS present with face pain. That's their very first symptom, and it's years sometimes before they get their next symptom. So I've certainly, and I know Jeff has, we've actually written papers. I think Ray Sakula was our senior author, talking about people with clear-cut type 1 pain who subsequently turned out to have MS. About 3/4 of them did have a vessel. Now, the problem, of course, is blaming the MS, blaming the vessel, blaming the nerve susceptibility because of the MS. We're never going to know. It's not going to get enough people. But that's my point. We can wind up operating on someone who later develops MS and has recurrent face pain. Second, though, is any of us doing the surgery know that when we're moving the vessels and putting in the felt, indeed the nerve, which is already injured, can decide to either get further injured and therefore react badly, or it can not recover, meaning that when the patient comes off the steroids, or however you do it with weaning the meds, there may be either residual pain not recovered, or in fact, pain being worse because the nerve has reacted badly to the surgery, to the presence of the Teflon. For Dr. Janetta and myself, when that happened, and it certainly did to us, hopefully not a lot of times, and I don't even have off the top of my head a number, but the point was we always would say to the patient, 2 options. We can go back in through the very same wound in a day, like right away, take the felt out, which presumably in our humble opinion might be part of the problem, whether it's pushing the nerve or whatever it's doing, and then do what's called an internal neurolysis, where we comb the nerve fibers, because a fella in France, Michel Sindol, who after his first 4,000 or 5,000 of these said, hey, this is really helping people who have kind of a funny pain, or worse, you get in and the nerve is badly damaged, and you know, therefore, that it has what's called intravascular, or between the fibers, scarring. And so he suggested that this would help. So at least that's our experience with that. Going forward, if the nerve is injured, further things to injure it, gamma knife, radiofrequency, balloon, are always a bit of a trade-off, because you're not starting at a baseline nerve. You're starting with a nerve that's already indicated. It's more angry with us in particular for fooling with it. But at the same time, those may be options, but more central options which exist and would be something to discuss with the new docs is regional transcranial magnetic stimulation, which is an outpatient once or twice a month procedure that is clearly starting to help people who've moved along the spectrum. Because someone asked earlier about it, and in your case, I needed to remember to say this. We have fairly good longitudinal evidence that type 1 patients, if they either don't get treatment or choose not to get treatment or are lost, tend to quickly, over 12 to 15 years, which for me is quickly, turn into type 2 patients. In other words, they have more neuropathic pain, more persistent pain, more long-lasting pain, and then they start to get different aspects of the pain, either more tingling or more numbness or more phantom sensations. And then obviously there's one called allodynia, meaning when someone touches you or you touch yourself, it causes pain or discomfort. Anything that causes pain that shouldn't, called otherdynia. And that's what allodynia is. So those are some thoughts you might discuss with them. No, you agree that more internal things aren't going to help. The fact that those 2 medicines in particular, the duloxetine and Lyrica, were added is a smart move because they have a very good combination effect, so to speak, because they're all attacking nerve irritation from different angles. And obviously following the surgery and following a nerve that's gotten more irritated, we're never really sure exactly who the bad actors are. Is it acetylcholine? Is it the potassium? Is it the sodium that is what Tegretol stops and so on? So you start to add in other things. Does that help?
It does, but it's also confusing for the fact that now with this new MRI that's strongly suggesting MS, all of the past diagnosis and procedures have all been, I won't say misdiagnosed, because we were, we were told it was TN1. That was what the carbamazepine worked and the balloon worked. And then all of a sudden now we're at atypical and now at MS. Is that going, could it have just all been through, just like you're saying, the MS, that going back to square one and it wasn't TN? Like we just felt very confused. Like, is that going to change his I'm not sure how to say it, forward, like how we're going to deal with this, being that we really don't know if it's TN1 or neuropathic facial pain, because we're getting very different conflicting, not conflicting, but different views of it, even though all the doctors are looking at the same MRI.
At the time that you had the first surgery, or before the first surgery, he had an MRI, correct?
Yes.
That's why we do a pre-op MRI. For all surgeons doing MVDs, we have a little checklist.
Yeah.
Is there a cerebellar pontiangle tumor? Is there an AVM in the space? Does the patient have a small brainstem stroke? Do they have MS? Is there any sign of dural thickening? So on our pre-op MRI, that's what we're actually asking the radiologist to look for. If it wasn't there, we'll never know whether it was missed by the radiologist, which I think is unlikely given the fact of the places you just talked about, North Shore and Cornell, who've seen the films. The second is, though, that, as I said, people who present with face pain and no signs of MS are 5%. And all of us who do a lot of these surgeries have operated on these patients. Luckily, in a large number, we've helped their face pain, as I said, from Sakula's paper, but we have not for others, and we're not pretending that that's a good thing. It's just that we didn't. So whether the MS is now manifesting itself in the abnormal face pain, or whether it's related to the surgery, to the felt, or some irritation related to the surgery, no way to tell that either. Obviously, if you take the felt out a year later, it's not going to make a difference. So you may never know.
Okay.
But at this point, yes, you're carrying a diagnosis of, and they need to drop the word atypical. It's not atypical. It's neuropathic face pain. And neuropathic face pain has a fairly emerging pathway. Medicines like some of the ones that have been mentioned already by yourself and others are being tried. There are 2 new medicines that are coming out, the Noxema trial, or Noema trial, sorry, that is purportedly for TN is actually looking good for other types of face pain. And then, as I said, you move on. We just finished an article, I think it's coming out in that journal that they publish, about non-incisional, or I think they use the term wearable technologies. But the point is that the stimulation, the electrical stimuli, the regional transcranial magnetic stimulation, the vagal stimulation that's transcutaneous, the the low-level laser therapy, all these have emerged as having proof that they actually work in trigeminal and other face pains that are not cancer and not trauma related. So the point is that that's being pushed, and so I was doing motor cortex stimulation for people like your husband, but we're happy to be able to move away from that and do it with just transcranial. Yes, it's a bit of an inconvenience for the patient, the twice-a-month treatments or whatever, but it's certainly a lot less than the surgery and coming back for reprogramming and so on. So we think at the current time it's an acceptable trade-off, and it seems to be helping enough people that it's proving itself to be of value. Will there be a subgroup it doesn't work? Absolutely. There always is in our business. Somebody whose pain we're not getting to, which is precisely why we keep pushing for new medicines that look at the root of pain. We know, and I know the rest of the group has heard this or hope to have, this is a genetic problem. Patients who have TN, carpal tunnel, and different syndromes like that, where compression syndromes irritate the nerve, have a clear-cut genetic mosaic of the way their pain system interacts. It's not that it's a disease, it's not an enzyme that they didn't inherit, it's just the mosaic of how their pain system, what are called the vanilloid receptors and other receptors, how they get together to report pain. And they typically make what scientists in the lab are calling an overestimation of the response. And therefore the patient reports a heck of a lot more pain than in fact electrical signals firing per unit second in the lab said we would expect the patient to say, which is how we get this kind of estimation of data. But the point is that these medicines are designed, as well as these treatments, to calm things down. I know the organization has been talking to people about CBD and THC. We have a study going on with 2 strains on the West Coast that are genetically pure. In other words, they're very clear as to what's in them, and it's blinded right now, to me especially. So we have the people taking it, they take it on for 6, off for 6, on for 6, and we'll organize that data down the road. I know some other people in the organization swear by it. Nobody that we have records of, and PJ and I had and still have over 20, 25,000 people who we had contact with over our careers. Nobody's telling us they took CBD and got worse. That is from the CBD. Some people have overdone it and overdosed themselves, but it didn't worsen their face pain. Anybody else? I see waving going on up there.
Dr. Casey, I got a question for you. Do you provide telemedicine consultation for people in Colorado, just in case I need? Because finding a person who have expertise in trigeminal neuralgia is very rare. My family members are neurologists, but they don't know that much about that. So you take telemedicine in Colorado?
Because of the transplant, both my surgeon and then more importantly, my wife do not want me back in the OR because I got it from a Hep C infection, and hepatitis C, the only place I could have gotten it was in a hospital. So, however, I have been doing Zoom because the vast majority of our practice was always Zoom. PJ and I did not feel that everybody needed an operation. You know, we should try medicines, try local things. So yeah, I've still been doing probably 4 or 5 patient Zoom consultations a week. The only change from the patient standpoint is obviously I don't want to prescribe for them because I'm not their physician of record.
Mhm.
And I don't charge insurance. I send them a little note that says, since God decided foolishly to keep me here, I ask them to send a small donation to my church, and I give them the church's address. Figure I can't lose by trying to put a few extra cash bucks up there. Maybe the guy will say, we'll keep them on planet for a while longer. But yeah, I would see patients from elsewhere. They can go on the website, and the website will push them through.
Right, just the website I'm looking at is drkencasey.com, right?
Correct.
Thank you, sir.
No problem. But that's the thing, reassure them, don't worry about insurance. That's not the issue. The issue is to try and get good advice to their physicians.
Right, I mean, like I said, neurologists with, with your expertise, professional expertise, is very rare, just like hands, teeth, okay?
Well, sometimes we work together. As a person today, the neurologist called me. She had clear-cut geniculate neuralgia, and they kept saying something in the teeth and so on. And when I sent the letter, neurologist was kind enough to call and say, I 100% now agree with you, and we're just going to stop what we're doing and send her in the right direction. So I thought, okay, then it worked for her. Perfect.
Thank you, sir.
I have a follow-up question. The topic before had talked about the MRI showed possibility of MS. And so one question I have is I had an MRI just recently for my back. So they didn't say anything about MS. So does that mean, would it just a regular MRI show that as a possibility? And since it didn't say anything about that, then I'm okay. And then number 2, you talked about electrical stimulation a lot, and for some people, I had electrical stimulation going to physical therapy. And is it possible for me that irritated things and actually made me worse rather than better because I got worse after, doing physical therapy?
We'll do that first and then come back to the MRI. Electrical activity on the face, in particular, TENS units and the Cephalese bands and so on, for the right frequency, meaning how many times per second, and the right intensity, we didn't see anybody get tipped over for either TN or migraine headache, because those are the 2 groups in particular that we kept moving this technology on. So applying the patches to the neck for both what's called scrambler therapy, which is again coming up in this article, but it's a pulsed radio frequency. We didn't seem to make anybody worse when it was in the right spot. And no, we don't have any evidence that for the people it didn't work, and there certainly were some, that it made them worse. And that would have been listed for us as a complication, obviously, in the paper. For the MRI, unfortunately, the existence of spinal MS is 100 times more rare than cranial MS. And so a spinal MRI isn't likely to make any comment one way or the other. And thank goodness you don't have it in the spine. But down that low, most of the lower spine wasn't imaged anyway. And more importantly, that would not be the way to present. If you had MS, it would be on the cranial portion of the films that you'd see the changes with those complaints of peripheral changes.
Okay. Thank you.
No problem. Are we all good then? Sure.
Yeah, I had a question. I'm assuming that it's probably not possible to use transcranial magnetic stimulation on someone with a motor cortex stimulator, right? I'm assuming.
No, that's not true, especially if the motor cortex stimulator is off. Obviously, if it's running, I doubt anybody would try to see what would happen with the two sets of waves. But if it's off, remember, one's electrical, the other's magnetic. So there are two different forces here at work. When your motor cortex is on, it's sending an electrical signal. When the regional magnetic, it's sending a magnetic wave into the brain. That's what makes it transcranial magnetic stimulation. We realize that highly focused ultrasounds and so on were affecting their changes that way. However, given the probably general sense, especially among the psychology group who have most of the RTMS devices right now, because they got FDA approval for depression. Now, they are doing it for some face pain and so on, but they probably never heard of motor cortex. So their hesitation is going to be they have no idea what that is. They would not be able to find a paper that says, yeah, we did 100 people who had a motor cortex and it just won't be there. As you know, probably from Medtronic, we still are hanging at maybe 1,800 to 2,000 motor cortex across the entire country. So it's not that many people.
Okay.
And not all of them for face pain. Some,
wow.
I have a bunch in that are in for stroke, and that helped those patients.
I thought it would be something like an MRI where it's interacting with the wiring and creating strange fields and possibly damaging tissues nearby. So that's why I assumed that it was probably not something to try, but
well, I doubt they'll do it, is the short answer. But
yeah, that's what I was thinking.
Yeah, there wouldn't be a physiologic reason why it couldn't be tried. And therefore, I'll bet if we keep our eyes open in the next 5 years or so, somebody will get together and write a paper on that.
Because yeah, of course my stimulator's on one side, or the electrode's on one side, and of course the face pain's on the other, obviously. So I'm assuming that the transcranial stimulator would be on
the
entire head?
No, it'd be on the same side as the pain. Same side as the stimulator. The pain is controlled by the opposite cortex. So in your case, your right cortex is controlling your left face. Your right brainstem is controlling your right face. That's why we operate on the same side as pain. But the cortex is switched.
I thought he was not going after the cortex. Okay, so it is going after the cortex.
Oh yeah. It's stimulating. We have pretty good data now on humans because we can see it on some of the functional MRIs we've done. It goes down about 7 to 8 millimeters. And if there's the little groove in the brain, that's called the sulcus. When it hits the sulcus, it sometimes goes down another millimeter or so because nothing impedes its travel down the sulcus because it's going through the fluids. So it's kind of neat. And that allows us to change what's called the width of the waveform to see if we can change where it tries to go, which is what we were doing. When I started, we were putting deep brain electrodes right into these areas that had 4 little contacts and then bringing them out to a wire, same idea, and just stimulating that. But deep brain stimulation requires getting into the deep brain, the cortex, and not everybody's that excited about having something in the center of the brain. Parkinson's patients love it because it's been an absolute home run for them. Pain patients I have some in the frontal lobe, I have some in areas of what's called the thalamus, and people are like, plus minus.
Gotcha. Thank you, doctor.
Sure.
Thank you.
Did you say there was also a like a transcranial stimulation of the vagus, or did I mishear that?
It's not transcranial. It's actually you can either do it pre-auricular or in the neck. Mm-hmm. And just as we implant vagal nerve stimulators, this is done now percutaneously through the skin and affects presumably the same waveform. Obviously, the waveform we had when we put the electrodes on for people that got it, vagal nerve stimulators first for epilepsy, then for obesity. That definitely grabs the nerve current because we would watch the amygdala just change completely when the thing was on. I don't know that the ones done through the neck that we've looked at the amygdala and MRI simply because I'm not part of any of those studies.
Mhm.
Just a friend who's doing those studies was just telling me he's pretty happy that it clearly has a role. And as everything we try to do in medicine, he said, I didn't hurt anybody. I didn't make anybody worse. We just have to caution the patients that the pulse in your neck is your carotid. If you push too hard, thinking the harder I push, the more stimulus I get. If you occlude your carotid, you may pass out because that'll slow your heart rate down. I mean, that's a technique that's used in the hospital for people with extremely rapid heart rate. We just compress their carotids and the heart rate slows right down. But you don't want to do that with this device. But whoever is prescribing the device should obviously carefully go over all that.
Mhm. Does it have a similar effect to DBS then? Or is it like completely different?
Well, we don't know is the fast answer. DBS is definitely going through the thalamus and affecting what are called the thalamus to frontal cortex relays, the ones where we do our suffering. The perception of pain is in the thalamus where your body says, hey, that hurts, that has a temperature. But the suffering of, oh, goddamn, here it comes again, that's frontal lobe. DBS has its most effect on breaking that. And it was done purposely. You obviously don't want to take away any of the sense of sensation where someone may, not notice that their hand's on a stove and so on. There are people out there like that who have that from birth, what are called achannelopathies. But we never wanted to do that with the DBS, and fortunately the people developing it, that was always a clear goal. So DBS works one way in the thalamus. This appears to work primarily through the amygdala, which is tucked just at the bottom of your temporal lobe and is probably best known for the one that everybody says that's where your rage comes from. It's true, you do have that emotion in there, but the point is that it does a lot more than that. And it appears calming it really does a lot towards the transmission, but from that point on, I haven't seen a paper that described, at least truthfully, what, speculation what goes on, but not a paper that proved it with a functional image. But it hadn't hurt anybody. And so like most things in our field, give it a shot, see how many people say it helped. Try to do it where it doesn't cost them anything, like in a PT site and so on, but not always a possibility. And then Amazon will probably put one out tomorrow and people will be buying it left, right, and center from Amazon.
Okay, thank you. Thank you. I was on mute.
That's good. If we're out of questions, I can go keep my wife company.
Okay.
But I had fun. I always learn something when I do this, so I appreciate you letting us participate. Because just so you try to understand, when I do this, besides what we write in the journals and so on, trying to get information out for you, I'm talking about the FPA journals and so on. We also feed this back to the MAB during our things about saying, here's what we're hearing out in the countryside, so to speak. Dentists are still having problems. Neurologists still don't understand, nor do want to understand face pain by and large. And finding good ones has turned out to be a lot more difficult than anybody had anticipated, but doesn't mean we stop.
Thank you, Dr. Casey.
Yep, pleasure.
Thank you very much. We appreciate it very much.
You guys have a nice night.
Thank you. You too.
And I'll see what my wife is up to here. Leave, okay? And leave.
Well, does anyone have anything else that they want to talk about or bring up? And how are you doing, Tim? We haven't heard much from you or anybody else, I guess, who didn't ask any questions yet, or even if you did.
Pretty good. Few things as we pass the 80 benchmark. Few things break down here and there, but nothing severe that's going to take me out. Thank you for asking.
That's good. Good to hear.
Thanks, Brian.
Sorry, I was late. Meetings.
How are you doing, Aaron?
It's good that you're still working. I think that's
Yeah. Thanks.
I just had to come down to the kitchen and get an ice pack.
Yeah,
Make it-
they come in handy.
Yeah,
Did popsicles help?
yeah.
Like cold
Yeah,
in your
chewing-
mouth? Yeah.
Chewing on ice. Yeah, that helps.
Yeah. Yeah.
I
Yeah.
should buy you more popsicles.
Freeze my get brain freeze.
Yeah. I was just curious.
Is anyone else having success with Cymbalta and Lyrica also?
No, never.
Oh yeah, I have a lot of success with Cymbalta, I think, because I've had to stop it to try other meds. And immediately when I stopped the Cymbalta, my constant pain got worse. So I know it helped my constant pain, the Cymbalta did. Yeah, for sure. For
Allowed-
me.
Allowed him to go down 1,000 milligrams, so he's on only 800 now of carbamazepine, which is nice.
Good.
Yeah, he is getting some pain, but like Dr. Casey was saying, when he washes his face, mostly, and we're having success with that. But we'll see now when we seek out these other doctors for MS. That's the hardest part, is finding doctors. So that's a little tricky.
Yeah.
Yeah,
I would agree.
Yeah.
Yeah, it sounds like you guys have been really pushed around and pulled around with, different diagnoses and trying to figure out, is it right in the first place? Are you, do you want to believe the diagnosis and get it,
Right.
exactly. You don't know where to go. Oh,
His last MRI, which was just in the summer, and I had to really push for that. And that was just through our neurologist, who we just use just for our meds. And the last sentence, the last line of it says, "There is no clear compression of the trigeminal nerve." Yeah.
I've never
well,
had
good,
one.
they looked.
I've never had a compression, and I have had it on both sides, or I do have it on both sides. So, I mean, sometimes they just don't.
We had one neurosurgeon who said it's a clear compression, and others that said there's not. So we're not really sure what's there.
Did we run his by the Michigan neurosurgeon?
No, Tim, we didn't. I spoke with Dr. Casey after we saw, we went to Columbia. We've seen, a few other doctors, and then since the Cymbalta and Lyrica started calming things down for him, we just took a break. And now that we, seeing that it's possibility MS, then we're just going to go that route, and I'll see what's next step. Like, I feel like I wait for the pain, the level of the pain, the type of the pain, and then I call which doctor I think I need to call. But if we get a diagnosis of MS, then I'm going to go back to Dr. Sakula and see what he concurs with that or says about that. So we're just kind of, he lives day by day. We all live day by day here. So something pops up, then I call a doctor. Try to find a doctor.
I only asked because it was somebody out east and it wasn't you, sorry.
No, it was another one of the members from it was Tony, who she I think you helped her with the surgeon in Michigan. I don't know which ends up anymore. So like, Aaron was saying, I just don't know which ends up anymore. But I don't know if it matters or not, but I felt like if it was MS from the beginning, we would have had a different treatment plan.
Yeah.
And that's it. So I'm not even going to try to understand it right now. I'm just going to wait for what the doctors say.
Roseanne, I got a question for you. Did you see Dr. Casey in person or by Zoom?
Zoom.
By Zoom.
Yes.
What's your assessment of Dr. Casey? Did he help you guys?
He was willing, well, at the time, we weren't on Lyrica and Cymbalta, so at the time, we were just dealing with severe pain. And we sought out Dr. Casey when Dr. Brown retired. And like I said, Dr. Brown said he saw a clear compression. Then we went to another neurosurgeon in Manhattan, said there's absolutely not a clear compression. It is post-traumatic pain, because my husband did fall in 2016 and he fell and he did bang his face, slam his face. And the doctor just said it's from that fall. And then I contacted Dr. Casey because I had spoken to him on another support group and I just wanted his opinion. And I said, what do you think? And he, told me his thoughts on it. And he was going to write us a letter to send it to Dr. Linsky to see if he can add, given his opinion, if we sent the records. And it just so happens at that point, we met an orofacial pain specialist here in New Jersey. I'm in New York, but we went to New Jersey and he started him on the Cymbalta and Lyrica, and things just calmed down and we just needed to calm down. We were, the stress of all of that was making his pain even worse. So things calmed down with the medicine. And now that we have an MRI that's indicating a strong possibility of MS, now we're just focusing on that. But he was going to write a letter on behalf and contact Dr. Linsky for us. I will call Dr. Casey again if need be, but right now we're just going to take this path. We're on a different road right now. I'm just going to follow that road to see what our next steps would be.
Yeah, he seemed to be quite compassionate and also very knowledgeable to me. That's why I'm asking whether something you would recommend.
He was my doctor, Michael.
Okay.
He
He seemed to be so knowledgeable and very compassionate, and I'm very impressed with him.
All those things.
Mm-hmm.
Yeah.
I'll tell you this, he told us he was going to call at 9:15 a.m. on a certain date, and he called at 9:15 a.m. on that date, and I sent him all the records, and he had everything, and he looked at all the MRIs and everything that I sent him, and he had it all ready and was ready to discuss with us. So he was very helpful and comforting.
Well, thank you, Aaron. And I guess that your partner, that essentially you got, introduced us to Dr. Casey. I mean, essentially, he seemed to be just a kind of person that we want to hear from. Thank you so much, Aaron. Danielle.
Thank you. Yes.
You're very welcome, Michael.
Thank you, sir.
He's also, Michael, a frequent contributor to the facial pain, the
magazine,
the quarterly magazine. Yeah,
Right,
he's
right.
been on that. He did a successful MVD on me on my left side. The right side was, I would say not successful. It just didn't make any difference. I have always had the pain, but it's usually, unfortunately not today, but it's usually managed by medicine. But every so often with the change of season, there's like, and I also had a mistake with my medication in the last week. So it's been a struggle, for me.
Yeah.
But in any case, I would recommend talking to Dr. Casey about.
Yeah, it's
anything
very
you
hard to
need.
find a neurologist that's so knowledgeable about facial pain. I mean, it's
And he will send your primary care or whoever you have taking care of you with your meds. He will send them his thoughts and information. He's really good at that.
very, very nice guy. Last question. Anybody who had recently just got the latest COVID variant vaccine? They just came out a couple of days ago. Just anybody who had it?
I am not, no.
We're going to get it along with the flu shot.
Okay.
Yeah.
Well, let it know us go.
Yeah.
Maria,
I'm just gonna mention one thing. We'd sent out some letters to doctors and things like that to see if they wanted to join like the Facial Pain Association. We didn't really get much response, but I did use Medifine in order to, search for doctors who specialize in trigeminal neuralgia. And I was able to find some that we didn't really know about, or, maybe we did, but maybe they never responded. I don't know. But I guess I would just suggest maybe people can try to use that to find neurologists, because that we found a few that we didn't know about that were listed as being specialists in that. Now, we haven't ever made an appointment with any of them. I don't know if anyone in the group has or not. I think someone mentioned Dr. Biondo. I don't know if that was anybody who's on today. I think they were going to see him. So that would be one to, that's in Michigan anyway.
And
So I
how do you
just
how do
wanted
you
to
spell
mention
his
that.
name?
What was that?
How do you spell his name?
Biondo.
B-I-O-N-D. Okay. Oh, I see. Okay.
And there were a few others too, but we haven't got much response yet.
Maria, we have a pain specialist here if you need to see somebody for your right side pain.
Thank you. No, you've
Yeah.
always told me that. Yeah.
Aaron seeing him.
Yeah. No, you've mentioned that. So far I tried, her name is Christina Rose. It's Rose Neurology. Dr. Casey had given me her name. I've only ever had Zoom appointments with her. I don't think she meets you in person. I'm not certain why. She's a young woman. She seems reasonably knowledgeable about trigeminal neuralgia. So am I completely happy with her? I can't say yet. I've only had a couple visits, but she suggested a medication when I started having like burning mouth syndrome, which was real unusual for me. But happens. So she suggested some medication that ended up working and giving me some relief from that. Not complete, but most relief. So she's somebody that Christina Rose, but she won't meet in person. So I'm uncertain whether or not, like, what her practice consists of. But she has help. So
And what kind of a doctor is she?
she's a neurologist,
Okay.
and she's out of Dearborn, the Dearborn area, I think. Yeah, Christina Rose. Because when Dr. Casey when he came back from being sick, I was in conversations with him online, and I had asked him for some referrals or a reference, just any names of a neurologist, a neurosurgeon, like who he didn't mention any surgeons, but he did mention her. And I think there was another doctor. I'd given the name to you, Danielle, you and Aaron, but I don't remember who that was. Somebody out of Beaumont, I think. Both of these doctors are out of Beaumont or Corwell Health now. I don't remember.
Yeah, I'd remember I don't have that list in front of me, but
Yeah,
I think I remember which one it was. I remember that, yeah, Dr. Christina Rose, and then there was another one you gave us.
Yeah. I don't remember. Yeah, I'd have to see. I'd have to find the email from Dr. Casey. If I find it, I'll send it to Aaron, and then. But I know, Aaron, you mentioned that you had asked both doctors to speak at our groups, but didn't get any response. So that that happens. I don't know if it's just not in their wheelhouse to speak to groups or not. I don't know.
I was thinking about making an appointment to put him on the spot.
Oh, just walk in. Yeah, there you go. There you go.
Yeah, make an appointment and put him on the spot and see what they say.
Yeah, why not? Yeah.
Yeah, there was oh gosh, I've got the list here. It's just not in the right order. There was Dr. Andrew Biondo, Martha Rinke, Douglas Gleb, Wade Cooper, D'Souza Rose, yeah, Christine D'Souza Rose, and Thomas Juan Carlo.
Oh, it was Thomas Juan Carlo, I think.
Okay.
Dr. Juan Carlo.
Yeah, Danielle and I called their office and sent them letters, and we got no responses whatsoever. And we were told by somebody that if you're doing marketing, which is kind of what we're doing at that point, you gotta send something 7 times before they even look at it. So good grief, I don't know about 7 times.
Right. No, it becomes difficult because anyway, yeah. Oh, and I wasn't able to make the meeting last time with Dr. Jacob. I did look at the video a little bit. I didn't finish it. How was that received?
It was good. It was very good.
Was, yeah.
Yeah. So you were able to see it via the link though.
Yeah,
So
via
that's
the link
good.
I was, yeah.
Okay,
So
good.
does anyone, well, I don't know if anyone is looking for a neurosurgeon, so I didn't know if anyone had gone and saw him out that's local.
Yeah, I don't know.
Yeah. I don't, some days I think I will to get maybe something to do. But then I kind of like I have that spell of everything's great. So my medicine's working. I don't need to do that. Yeah.
Yeah, I understand that. Yeah, I get that way too.
Yep.
I go up and down.
I want to thank you, Danielle and Aaron. I need to sign off for now.
Okay.
See you
Thank
all
you
next
for
time.
joining.
All right, thank you,
Thank
Kim.
you. Bye,
Thank
Kim.
you so much, guys. And again, Aaron and Daniel, you guys, pull these things together, and I think we all appreciate, your effort, your time, and helping us. So thank you so much.
For sure.
Thank you.
You.
Thank you.
Yeah,
See you next time.
we
Bye-bye,
do
guys.
appreciate it.
Thank you, Michael.
Bye-bye now.
Aaron, was that Katie?
No, it
That
was
wasn't
Kim.
Katie. That was Kim.
Katie, okay.
Katie said that she wasn't going to be able to make it tonight.
At the last
She had,
minute. looked
yeah,
up.
she had family in town that she had to
Yeah,
be with tonight.
okay. Thanks, Aaron. And Danielle for your time.
I wish I could speak more.
No, that's okay.
Ask. Oh boy.
Does anyone else have anything they want to talk about?
No.
Complain about your pain, shout about it.
Yeah. Shake my
Tim,
fist. All I have to say about that is a week ago, I was in Cape Cod and I didn't have anything. So my vacation was great. And if
Oh,
if I had to
Yeah.
have pain again, then I'm glad it's not when I'm home. Well, you know what I mean? It would have been,
Yeah.
it would have put quite a damper on that week. And
Yeah.
I'm glad it did not. So
That's good. I'm sure there's like a lot of anxiety trying to go into a vacation and wondering if it's, if it's worth it, if you're just gonna be suffering through it,
Oh,
right?
shoot.
So
The
good that-
biggest anxiety is, did I
Yeah.
pack my meds? Finally, I decided, what am I doing? They're in my purse and they're on my person. Like, why would I ever put them in a suitcase
Yeah.
where I might have forgotten? It's silly. Yeah. So now those meds are like, they're like right here, close to me. Yeah, that's the worst. Getting across the country and realizing you forgot your medication. Holy crap.
Oh, I went through some stuff recently too with even the transfer from Rite Aid to Walgreens was a fiasco for my opiates. That
Okay,
was
I
a
bet.
pain.
Oh, I'm certain. I am certain.
The opiate script got deleted it in the Rite Aid system, or the Walgreens system couldn't access the Rite Aid system,
Right.
even though they'd taken it over. So I called the doctor's office and had to get a new script sent, which wasn't that bad. I had to get through the phone tree, which was immense for Dr. Gosh, what is my pain doctor's name? Tim knows it. Dr. Monair. But his office handled it great. Once I got to a person, they handled it perfectly, and it was done within 5 minutes.
Mm.
The other things I'm finding out too is that scripts are not transferable across state lines at all. Even between Walgreens to Walgreens, like Walgreens to well, even what did they say? They said even between pharmacies, one Walgreens pharmacy, you can't get it. You have to have a new script sent.
For an opiate, yeah.
Yeah, I
Yeah,
didn't know
rules are
that.
different than if it's like thyroid medication that I can get anywhere, but right. Some of these other ones like the gabapentin I take once before I go to bed. That wouldn't go across state line. Yeah.
Oh, and that one doesn't go across between
No.
pharmacy to pharmacy?
No. Pharmacy to pharmacy, I believe, but across state, like if I was on, is somewhere and I needed a refill, I couldn't get it refilled there.
Okay.
Yeah.
Okay.
I'm
we're
pretty
really
sure
tied.
now.
We're really tied to
Yeah.
staying in state and local.
Or having enough medication. before you
Yeah,
go.
yeah. And they don't allow you to have any more than 4 weeks supply.
Right. Yeah, that would be tough if you wanted to, go very far, so.
Yeah, no travel for me to Africa or anyplace. Not without having an extra week supply of everything.
Oh, sure, understood. But. All right, well,
All right.
been nice to see you guys.
Yeah, you too.
Yeah.
Hope everyone stays doing well.
Yeah, hopefully the weather will stay stable for us all, right?
Yeah, that I'm looking forward to that.
Thank you.
All right, take care.
Thank you
Thank
so much.
you.
Thank
See
you,
ya.
Denise.
Bye.
Bye-bye.
Bye.
Bye, Maria. Bye, Lynn. Thank you, Denise. Thank you, Roseanne.
Night.
Yeah, have a good night. All right, let me turn off the recording and the meeting.